already. We're here with Dr. Craig Levitz. We're going to talk about some of the biggest issues pertaining to injuries in young amateur baseball players. So first, in your opinion, doctor, what are some of the biggest reasons for the epidemic of Tommy John surgeries in amateur pitchers?
Well, I mean, there are multiple reasons. One of the biggest changes over the last several years, or probably the last decade, has been, the advent of year-round participation. So when I grew up, I'm a little older than you, pitchers pitched during baseball season. They were the quarterback of the football team. Maybe they were the center of the basketball team. So they pitched basically only during baseball season, maybe over the summer in a good summer league team, maybe did a little training. Today, more and more we see sports specialization where athletes are throwing year-round. The biggest counseling I have to do is, stop, take a time off. My favorite quote is the Mariano Rivera quote, who I knew from my younger days when I trained with Jim Andrews. And he used to tell everybody that at the end of the baseball season in October, he would take his glove, put the ball in it, put it at the top shelf of his closet, and not touch it till the first day before spring training. So even at his level and with his need for command, he was taking 3-4 months off in the winter. And that's why everybody would say, oh, God, what's wrong with him in the beginning of the season? It was that was his training, and that's how he preserved his arm and was able to pitch all those years. So I think that's one thing, not enough rest, because they're playing sport-specific. The other thing is we're diagnosing it better. So you got to remember there's a lot more doctors that are trained in diagnosing injuries to the ulnar collateral ligament that were unfortunately missed years ago. Oh, you got a sprain, strain, it's a little leaguer's elbow. So people that had these injuries were underdiagnosed. So we have an increased ability to diagnose it, as well as an increased cause of it with the extra innings that we're pitching. So some of the surgery is just because we're recognizing it better, but some is just the change in the landscape of baseball training.
Mm-hmm. Now you mentioned Dr. James Andrews, obviously a pioneer in the arm care industry. Can you tell our audience about some of the biggest takeaways from your time with him and what makes him so successful?
Well, I do believe that's the key to my success was my time with him. The baseball elbow or the throwing shoulder is really unique. 99% of orthopedic surgeons, even shoulder and elbow specialists, have had very little training in the actual throwing elbow or the actual athletic elbow and shoulder. And that's because there's not that much of it. In a given day in the community, you see some here, some there. You got to really be at a center like Andrews where you're seeing 50 baseball players, quarterbacks a day in order to see these injuries. So it's a tremendous advantage to have all those patients because every day you're learning, every day you're getting them, and your volume is through the roof. So that just makes you a better doctor and a better surgeon. And that's what Andrews had. I mean, he would literally see in a given day the volume that doctors see in a lifetime. So he was able to hone his skills early on by attracting these patients. And then he's just got a tremendous personality. He's just really on top of everything. He treats people in a different way. And, I've tried to pretty much become a carbon copy of that in my practice. But it's really that volume that we have when we're down there that enables us to really treat the athletes at an elite level, to recognize things. Even some excellent docs can't. To do these procedures in a way that gets them back faster and quicker. Because we've done thousands of them where, the best docs in an area maybe do 20 in a lifetime.
Mm-hmm. Now, being in the Northeast, in my opinion, it's a blessing and a curse for young pitchers. From a scouting perspective, there's not as much mileage on them, so they're probably less of an injury risk, but at the same time, they also don't develop the same velocity as some of our counterparts in the Southeast. Now, would you say that the Northeast pitchers are a little less susceptible or more susceptible to the torn ulnar collateral ligament and shoulder injuries?
I mean, I think you hit on the two balancing factors. So in the Southeast, they're throwing year-round and they have good weather, so they actually probably put more volume on their arms. But the counterpart of that is our muscles protect our ligaments in our shoulder and on our elbow. And it's really hard to get those muscles loose in particularly the spring baseball season. The last couple of years, March has been horrific. And I can't tell you how many kids I've seen, because their coach sends them out there and like, okay, you're, a varsity pitcher in high school. You should be able to, give me 90 pitches. 90 pitches at 35 degrees is like 200 pitches, in Miami. So I do see a tremendous amount of injuries in the early March area when it's just too cold to get loose. So I think it's a balance both ways.
Many pitchers, notably Masahiro Tanaka, have been diagnosed with partially torn ulnar collateral ligaments and opted to forego surgery in favor of rest and rehab. Many times it's not successful. Would you say he's an anomaly, or is there more cases like that surgery can be avoided?
Again, a little yes and no. So during my time with Andrews and afterward, we've taken care of many athletes with partial tears of ulnar collateral ligaments and avoided surgery. We're able to do that in a lot of them with PRP and stem cells and alternative treatments. That being said, the ligament never heals in those cases. It's never normal. And Tanaka's a perfect example of what goes on. So they can still throw, but when Tanaka came over from Japan, he was throwing 99. Now he tops out at 93. So it does affect you even when you have a partial tear if you try to pitch through it. That being said, I would say the majority of patients were able to avoid ulnar collateral ligament surgery and keep them going, particularly our high school kids that, it's really hard to miss a year of baseball when you're a prospect in high school or younger. So we really try to get them through their high school years with any way we can and allow them to still be effective. And then if they choose to have surgery, they can redshirt during college and have it done then. If you look at examples, Zach Wheeler pitched for 2 years with a partially torn ulnar collateral ligament. He waited till he got to level. From out east, the Mets pitcher and Steve Matz. Yeah. He pitched with a torn ligament. His was completely torn in high school. He was so darn good that he could strike out Suffolk County with a torn ligament. I mean, his first Mets physical, he had a tear. So there are you can pitch with an ulnar collateral ligament tear, and in some cases, it's worth trying to avoid the surgery until there's a better time in life, like a redshirt year, or after you're drafted, to get it done. And there's many techniques. In addition, one of our bridges now also is a new surgery that's pioneered out of the American Sports Medicine Institute, which is where Andrews came from. He's not there anymore, but just like myself, he left behind a couple of fellows there, and a technique that's been developed is where we actually are able to repair the ligament and use like a little ligament suture brace. And why it's not as good as a reconstruction, the recovery is only 3 months. So it is a nice bridge for the high school athlete to be able to keep going for 2 or 3 more years, and in some cases forever without having to reconstruct the ligament. Problem with that is we don't know the long-term results. We don't know if you can get a year, 3 years, or 5 years because it's a very new procedure.
Mm-hmm. And what are your thoughts on the PRP injections?
It's my first line with any ulnar collateral ligament tear. It's the perfect scenario for that. I think PRP has been polluted a little bit because everybody's using it for everything, and it doesn't make sense for a lot of those uses. But when done properly, it can really help. Now the problem is, people go to anybody sometimes for a PRP injection. Well, you should really go to the surgeon that's going to reconstruct your ligament if you need it, because knowledge of the anatomy of that ligament is key when you inject it. You want to be able to place the needle right into the ulnar collateral ligament. The ulnar collateral ligament is like a third the size of my pinky. It's tiny. So you really need someone that knows their way around the elbow that can inject the elbow properly. But it's worked miracles. I mean, a couple of years back, I had a kid that I was almost sure we were going to have to fix. And I injected him. I didn't know what happened to him. I know he was going on to play at Duke, and I figured he went somewhere else and got it reconstructed. Shows up in my office, 5 years later for a knee problem. And he's like, "Hey, Doc, I pitched 4 years at Duke, had no problems. It was great." And I was like, "Whoa." So there really are, anecdotal, practical miracles with PRP. But it doesn't work for everybody. But I do believe it should be your first line defense in treatment of that. And it also works well in rotator cuffs as well.
Mm-hmm. My last question, obviously with the tournaments and showcases being such high-pressure environments for kids, they tend to throw breaking balls at a younger age. What is your take on that? When is too young or an appropriate age to start spinning the ball?
Well, that's a complicated question, but we have done in my time with Andrews and after that, a lot of research in this area. And part of it's going to sound crazy, but there really is never too young an age to throw a curveball. That's a fallacy that we've disproved. It's really throwing a curveball when you're tired. So that's what we've seen to be the biggest stress on the ulnar collateral ligament. So that's why pitch counts are key. And what I counsel most of my athletes on is, I'm okay with you throwing a curveball. You want to, the first inning, you want to keep them off guard a little bit when you're fresh. Even if you're 10 years old, you want to throw a little spinner up there to get something going in their head. By all means. But as the game goes on, once you get past 30, 40, 50 pitches, depending on your age, fastball changeup. And that's what really, we emphasize the same thing to our young pitchers as the pros do to their pitchers. I mean, if I asked you what pitch is the difference between, a Cy Young winner and the guy that can't get out the minors, most good pitching coach would be an incredible changeup. And that's more powerful than a curveball, and that has no effect on your arm at all. So we encourage kids, if you want to play with off-speed stuff, play with the changeup. Do that later in the game. If you're going to throw a curveball, do it early. A curveball and a rested arm really has no stress. It's when the arm gets tired that it causes problems. We also counsel kids on, I call it the Dwight Gooden approach as he got older. Stop trying to strike everybody out. Pitch like a major league pitcher does. Make them hit the bad pitch. Lower your pitch counts, get through more innings, and save your arm.